I'd like to invite Michael Borger. We'll have discussion about your talk, Gilbert, with the next case presentations. Michael is going to have a case scenario session. We'll invite the panel up here, Dr. Kachroo from WashU, Bo, you can come back and defend your honor, Bo. And we have about 25 minutes for cases. Thank you, Michael.
Thanks a lot, Moral. I have two cases to present. Before I get started, first of all, I would just like to say to Moral, also to AATS Foundation, David Bobbitt, and the rest of the team, this has been a fantastically organized meeting, and I can only say congratulations. Everybody seems to be very excited and have learned a lot this last day and a half. Thank you. These are my disclosures, but my biggest disclosure is that for 10 years I did my cardiac surgery residency training and also worked as a few years as a surgeon with Tirone. Tirone, this is from 2005 when you were the AATS president. This picture and all the other pictures, and when I look at you now, you look the exact same. You're the same age. I don't understand what medication you're taking, but please tell me what it is. And I was just so proud back then because I thought, wow, I'm part of a team from Canada, and our boss is the president of the AATS, you know, the most respected cardiac surgery society in the world. And I thought, this is amazing being part of this team. But then if I look around this room here, I see a lot of people, even ex-AATS presidents, but also a lot of people that I see at other meetings around the world giving talks that I know are the go-to cardiac surgeon in their countries, and they're still all sitting here watching the whole time. Every time you talk, they're, you know, putting their phone down and looking and listening. It's amazing how much knowledge you've imparted upon us, and then we've imparted upon people in our countries, and literally hundreds of thousands or maybe even millions of patients you've affected directly or indirectly. So thank you so very much, Tirone, for everything you've done for our patients. Huh? So this first case, David Bobbitt also said to me yesterday he was impressed by the fact that although this is a technical meeting, a lot of it is just about decision making, and this is, I think, a good example of that, but it also touches on a lot of the topics that were already brought up this morning. So this was a 59-year-old female. She was an international patient there in Leipzig that had a 12-month history of increasing shortness of breath. The reason why I say that she's an international patient is because it took her a while to get back to our center. She was seeing locally, had several different opinions what should be done before she eventually made her way back to us. She is a small woman, 145 centimeters, 54 kilograms, a BMI of 26, mild kidney insufficiency, but otherwise medically fit. These are her medications, so she's on good doses of heart failure medications, considering especially her body size. And despite that, and the most important part of her information is that she had a perimount put in, a 19-millimeter one put in 2013. The operation was complicated by the fact that there was an RCA obstruction noted intraoperatively, and she had an emergency vein bypass to the right coronary artery. And then a couple of days later, even was on our step-down unit, had a short episode requiring resuscitation CPR for a minute because of non-functioning pacemaker wire and a lack of any underlying rhythm, and therefore she underwent a pacemaker insertion. Since then, she did well, but had increased transvalvular gradients, which is, you know, understandable with a 19-millimeter valve. Her first pre-discharge echo had shown a gradient of middle gradient of just 12. However, her LVEF was only 45%, probably related to that right coronary artery problem intraoperatively. But the next time that we saw her was 5 years later, and she now has increased gradients with a mean of 27. You see EOA is also decreasing. However, the EF was increasing. It had now normalized. She also had some mild MR and TR, and the ascending aorta is 45 millimeters compared to 42 millimeters in 2013. So maybe I'll just start with Joe Wu at this point. Joe, what sort of things are you thinking about at this point? By the way, she's totally asymptomatic in 2018.
But she has a year of shortness of breath now, right?
Correct, in
Yeah.
2024.
Yeah. So, and she's got, let's see. So she has at least a valve smaller than 0.7, right?
Yes.
Yeah. Okay. And an ascending aorta after BAV, AS. I think she needs a reoperation, and I would do a biologic valve conduit Bentall.
In 2018.
I thought we said now.
Okay, no, I'm not coming back to now
Oh,
yet. I'm saying, what do you think about
Oh,
2018?
you're asking about
Yeah.
what are we thinking in 2018?
Yeah.
2018, valve area 0.7, 45. Well, we know you didn't do a biobental in 2018.
Correct.
We probably would have done a biobental in 2018.
So, asymptomatic aortic stenosis is on everybody's tongue now and will be a big issue in the upcoming valve heart disease guidelines, which will be presented, by the way, at the end of August and published simultaneously in European Heart Journal. So she's asymptomatic, but she has aortic stenosis then. Mark, what do you think?
I'm a pretty conservative surgeon. She's now 64. She's going to need her valve redone at some point. I don't think with a 19 you can do a TAVR. You'd probably have too high of a gradient. I know I'd have to defer to the TAVR surgeons in here, but what we're going to do down the road is fine. She had a very tough operation, right? Her right coronary was occluded. A biobental may not be all that straightforward. I would hold off on doing anything right now. She's okay.
Yeah, so just so everybody knows about the, asymptomatic aortic stenosis, the data that suggests that you should be operating on patients earlier if you have certain triggers like velocity over the aortic valve more than 5 meters per second. Those data are all based on first-time AVRs, not on redo AVRs, okay? So redo AVRs are slightly more high risk. This one, I would say, particularly a lot more high risk because of the small aortic root, because of the difficulties they had on the previous operation, small woman. And therefore, we definitely said back then, look, we'll just continue to watch you. The TAVR definitely, I would say, is off the table. I don't know if there's anybody here that would disagree with me, but the gradients are going to be way too high. You're just kicking the can down the road, and you're going to see her 1 year later, and then you'd be doing some redo Bentall after TAVR and SAVR. But I do want to remind everybody the UK TAVI data, which was just presented 2 weeks ago at EuroPCR. Please look at that data very closely. It goes along with what Brad Lenshaw was showing in his presentation. Stroke is statistically significantly higher 5 years after randomization compared to SAVR. Hasn't been published yet, but it was presented publicly there, and you can find the slides online. And if you look even at the Evolute low risk or the Partner 3 trials, you'll see surgery had a higher stroke risk at first, but then TAVR catches up over time. Surgery stays stable after surgery. TAVR catches up to it. So there's something about TAVR, probably these benign health things that are leading to more strokes in TAVI patients. And as we move into younger and lower risk patients for TAVI, we have to remember that.
Dr.
Michael.
Borger, I just have a quick question. So in these patients with moderate AS, looking at the ones who will, do worse later on, is there any role, as, Dr. Adams does for the mitral, to get cardiac MRIs earlier on these patients to look at, if there is scarring or some sort of enhancement on gadolinium?
That's a great question, Puja. It's not as linked to aortic stenosis, the fibrosis that you see, like for arrhythmic mitral valve prolapse. Arrhythmic mitral valve prolapse, though, don't forget, that's a very localized fibrosis, and then you have the trigger and the substrate. With aortic stenosis, this is very diffuse fibrosis everywhere in the ventricle, and the data just isn't hard enough yet to routinely recommend that.
Well, I just thought for the severe AS patients who have, fibrosis, they actually don't do as well with early TAVR or early aortic valve replacement as those who don't have that. So that was where the distinguishing mark for patients we don't operate on for severe AS asymptomatic?
Yeah, I would say the jury's still out. We need more data. So
Michael,
now-
one quick question. Your center did the surgery in 2013, right?
Yeah.
Yeah, so I mean, we always get these patients and we say, oh, they downsized the valve and referred in as, borderline surgeon. We'll fix it all. We'll go do a biobental. Obviously, you guys had trouble with that first operation.
Yeah, and to be honest, I couldn't really figure out retrospectively why she got a 19. We should have done an annular enlargement and put in a bigger valve. This is something I learned from Tirone 30 years ago here already in Toronto. We put a lot of Hancock 2s back then, and the gradients were higher, so we wanted always to put a bigger valve in place. In any case, for some reason, it wasn't done, and now, cat's out of the bag. So now here's how she presents now. The gradient is very low across the aortic valve, but the aortic valve area from velocity time interval is 0.5. LVEF is markedly decreased with global hypokinesis, and those are the left ventricular dimensions. And Puja, do you have some comments in here?
She's late to the ball game, I guess, but definitely higher risk at this point. Redo patient, she's obviously has the indications for a valve replacement at this point.
Yeah, so she's very symptomatic now, but what do you think about her gradient?
Well, it's probably due to low flow across her LVOT, so I'm sure LVOT VTI is also low, so her dimensional index overall would probably...
Right, yeah, I think we would all agree. This is low flow, low gradient AS, severe AS, or pacemaker, so patient prosthesis mismatch, but it's getting worse. Now she's very symptomatic, and unfortunately, for 6 months, she was, like I said, seeing many different specialists back home, and now, in the meantime, these are her other echo findings. And
Michael,
Maura?
just a comment. This is sort of all comes back down to, she had the wrong operation at her first presentation, and this is why we see these young, she's like 47, 48 years old at the time, small outflow tract, obviously, she would have been an aortic stenosis, sort of an ideal setup for a Ross, but now with the prosthetic valve, no one wants to go in. There was a vein graft already, the EF was okay, the gradients are only moderate, but by the time she actually gets to you, now the LV's, dying, and she has multivalvular. Now she's missed the boat and this is why her survival will not be back to normal.
Couldn't agree with you more. I actually sent a few months ago one of my surgeons to Ismail for a week. He saw 7 Rosses in 1 week. He's a really good root surgeon. His name is Dashkevich, and he's now done 20 Ross operations since he's been back in Leipzig. So it's no magic to it, but if you're a good root surgeon, this is the perfect patient for the Ross.
Michael, that interim of 6 months, did her ejection fraction fall from normal to 25?
No, it was already low by the time she got her first echo, but the MR and TR had gotten worse.
Yeah, okay.
So it looks like her ascending aorta is huge here, but it's only because she's very small and her descending aorta in relation is small. Like I said, the maximum diameter is 48 millimeters. There's the vein graft to the RCA, which is occluded now, so that you just see the little nubbin there. She probably didn't really need it. Her native RCA is open, which you'll see in just a moment. But we're coming down the aorta here. You see the left main starting to come into view now. And you see the perimount valve without really any calcification, at least on CT, of the leaflets. But you see that huge bar of calcium underneath of the valve, which Tirone was talking about in the septum. You also see that the right coronary artery is very close to the sewing ring of the valve. So big bar of calcium going down into the muscular septum. This is what her echo looks like, biventricular function. So left ventricular function is terrible, right is still probably okay. You see the pacer lead there. And this is a TE done with the flow acceleration across the valve. The leaflets are still moving, but obviously things are not as good as they were 12 years ago. And here's the gradient across the aortic valve, like we said, low, but we're talking about low flow, low gradient aortic stenosis now. This is the echo, the TEE pre-op showing the mitral regurgitation, and This is the best views I can get of her tricuspid valve, moderate to severe TR, as well as this pacer lead. So just to summarize, low flow, low gradient aortic stenosis, very small, 59-year-old woman, 19 perimount, severe LVAF 25%, moderate to severe MR, moderate to severe TR, ascending aorta 48 millimeters. Are we going to operate, and what's going to be our operation? Bo.
Do you have a debuliment study, stress study, to see if it's respond to any inotropics increased gradient?
To be honest,
do that.
I didn't bother doing it because to me this was just a clear indication for surgery, and I didn't see how it was going to change my management at all.
Yeah, if he has increased the gradient, then we know that there's a nice response to inotropics. I would do this one. I definitely take it out. I'll repair the mitral, repair the tricuspid, and do ascending replacement, do a root enlargement. Probably I can put a 25 for this lady.
Joel, you look a little bit skeptical there. What do you?
I mean, that's just a long-standing argument between Bo and myself about annular enlargement versus Bentall's. So,
Okay, so you would go with Bentall.
Yeah, well, there's a 48 millimeter ascending aorta, so you basically have an indication there to take care of the ascending aorta. I think my argument is people, unless they have some really strange congenital abnormality where their LVOT is mismatched for their body, in which case they need a cono, most people just have an LVOT that they have. And all you need to do is you need the inner diameter of your prosthesis to match the LVOT diameter. So Bentall solves that essentially every single time because you have all of the outer diameter and outer structure of the prosthesis outside of the diameter of the LVOT. That's what Bentall gives you. So Bentall is a solution, I think, every single time for a very, very small so-called aortic root or annulus. You just need something that's the size of the LVOT. That's our standing argument for this patient. I would have reminded you that I wanted to operate in 2018, and then I would go ahead and do a BioBentall.
And the mitral and tricuspid?
With a stented valve, Joe, or a stentless?
Yeah, stented, right. So
Like-
just a bio, like a magna, inspirus, whatever sewn into the bottom, in this case of a straight graft. I think you might have some issues a little bit with that right coronary button, but typically you can mobilize it. And you don't have to worry about putting the vein graft back on. I would do a transseptal approach to the mitral and tricuspid, and I would probably have a low threshold for having a balloon pump around.
Okay, Maral, I can see we're running kind of short of time, so I think I'm just going to present this case. But Gilbert, say her kidneys were bad or liver was bad. Liver is fine. Is there any way to do a transcatheter option for this woman?
I mean, I wouldn't. You had a right corner obstruction to start with in the first case. Imagine you try to fracture and put a TAVR in, you got to occlude the root. I mean, even though the aorta is dilated, not to mention that it's grown, you can run the risk of dissection. Then you basically have the emergency. And that's only a single. That's the problem, with cardiologists, that they think singularly. This is a multi-valve disease plus an aortopathy. There's no transcatheter option in these patients. Even you could stage it. So I don't. That's I think I know this is a surgical meeting, but still I think this to be emphasized in cardiology meeting more so. And again, unless you understand these kind of nuances from a catheter standpoint, you can't talk intelligently in those meetings.
Yeah, so just to stick with that for a second, the right coronary button, I know I only showed the CT once, but takes a long time to run it. But the right coronary button is right on the sewing ring.
Yeah,
and you get a
exactly.
neoskirt when you do a TAVR valve and valve. And if it's not perfectly aligned on the commissures, which is tough to do, you're going to obstruct that RCA.
Not to mention the sinus sequestration. This is all this issue with the thrombus that you see, right? And there's no washout, so you basically have delay obstruction. We've seen that, and that's been published. And those are very high mortality. It's not a cute thing that, it looks good, you leave. It's like 24, 40 hours later in the ICU, the patient suddenly arrested in front of you. You wonder why. It's because there's a delay obstruction, there's slow flow, and then obstruct afterwards, particularly these high-risk low coronary, small sinuses situation.
Merle?
But Gilbert, this is just off the table anyway, regardless of the coronary issue. It's a 19 millimeter valve.
That's my point.
Having-
You can even say 25. I mean, that's I give you
Having
that.
said that, Morale, I can guarantee you, if I was at a cardiology meeting right now, probably half of the group would say, yeah, we do a TAVI valve and valve, and then we do a tier, and then we do a T tier, and then, yeah, yeah. Okay. Sorry?
Puja.
Sorry. Oh,
Okay.
Puja, sorry.
Yeah, no, it's okay. You know, obviously, I mean, for me, I would just say the aortic valve replacement is probably the most important thing to do in this patient. So whatever gets that, I personally wouldn't do a root replacement if you can just do a limited, a Nix enlargement just to get a larger size valve in. She doesn't clearly need, you know, an extreme size in my hands, I think. And then obviously repair the mitral, the tricuspid, you know, if there's septal impingement, you know, with that pacemaker lead, I would think about potentially changing it out to an epicardial system. And the last thing on my mind would be the aortic, ascending aortic, even though I'm an aortic surgeon, just because she can always come back for that if she survives this.
Okay,
Yeah,
so
that's one of the things, you know, we talk about all this surgery, oh my gosh, we got to do this because it's lifelong, we got to do this. Pedro Del Nido operates on every single one of his patients 3 or 4 times, and he doesn't, you know, think twice about it. It's what I always talk about with aortic dissection. You know, the average surgeon's just got to fix that ascending aorta, and if the arch needs to be done later, you know, let somebody else do it. It doesn't have to be one and done.
Okay, so I'll tell you what I was thinking. I was thinking redo Bentall, mitral, tricuspid, especially in an international patient, and they're stuck in your ICU for a few months, and everybody's very unhappy. I was like, What I liked was the fact that her MR and TR had gotten worse over the last few months, and her annulus was not dilated. So I actually said to her, look, there's a chance I might leave the mitral and tricuspid alone, and then look at what happened. So this is her intraoperative echo, bad LV, but another thing I want to point out, which you could have seen on the CT, look at the thickness of her ventricular wall. It's still thick. It's not thin. And if you looked at the dimensions, it was 47 millimeters in diameter and 43 in systole. That means it's not a burnt out ventricle. And then here's the aortic valve. We already know that this is a problem. But here's her mitral valve, completely under full anesthetic, unloaded. But I was like, annulus is 37. No. And here's her tricuspid valve. Yeah, moderate TR, but the annulus is 36. So,
The pacemaker.
so this is what I routinely do for resternotomies. I put femoral wires in the femoral vessels just in case. Then do the sternotomy. We cannulated the arch. We gave Del Nido, cardioplegia. We removed the CEP valve, and it was actually just mildly calcified, but there was severe pannus all around the valve. And then we took out this huge bar of calcium going down into the muscular septum. Then I did a Bo-Yang aortic root enlargement. I didn't use the 37 David Adams valve, but I did put in a 23 Inspiris, which I think it's totally reasonable for this woman. We replaced the supracoronary ascending aorta with a HemoShield graft, and surprisingly, she came off pump absolutely fine. And here's her intra-op post-cardiopulmonary bypass echo of the LV, and look at that compared to the pre. Okay, so she had reserve. She definitely had reserve. Here's the new valve, much less turbulence across the valve. Here's her post-bypass mitral valve, totally competent, and then the TR is still unchanged. And she was extubated actually 6 days post-operatively, transferred to the step-down unit the next day, and to the floor 3 days later. And this is her pre-discharge echo. The gradient is also still low, but the EF has gone up a lot. It's basically gone up 50% relatively. So there's her pre-discharge echo compared to the, compared to the one before. I think you can all see that. Yeah, there it goes. Big difference, huge difference, just with relieving the aortic obstruction, which is shown here. And this is the mitral And again, the tricuspid, sorry, it's mild to moderate tricuspid now. So she was discharged on postoperative day 14, and I just wanted to take you through the decision-making process that we went through, which luckily in this case went very well. Thank you very much.
That was great. Thanks, Michael. Oh, yeah, we got a couple questions.
Can I just make one comment? This patient had patient-prosthesis mismatch, didn't have a stenotic valve, right?
But
When
it
you
was there was PANAS on top of the PPM.
Oh, there was, yeah, because, I mean, the valves opened really quite well. I just want to make one point about TAVI. Everybody poo-poos TAVI. This is a different case. This is something else. I mean, she had aortopathy and she had patient-prosthesis mismatch. But there are patients who have a burnt-out ventricle who I think TAVI is appropriate for as a bridge to. And I think that we have to think about that. Somebody comes to you with an ejection fraction of 10%, has very severe aortic stenosis, is in shock or something like that. I personally think it's good to put a TAVI into that person, wait a few months or even a few years until something like that changes as a bridge to operation. We do it for VADs. Why not do it for aortic valve?
That's kind of expensive. That, I mean,
Well, it's expensive, but also 10 days or a month in ICU or ECMO afterwards, or et cetera, is also expensive. But I think we have to start thinking about a TAVI potentially as a bridge. I'm not saying in everybody, I'm saying in some individuals.
Puja, are you guys doing that at all?
I think in this case, we couldn't, just because of the
No,
right
that's what I'm saying.
coronary.
This is a
Yeah.
different case.
But are you doing it for select cases?
Staged in cardiogenic shock, I would say it's a very rare, but an indication, I guess.
but one of the issues at my center is that the administration is heavily focused on the TAVR outcomes. And if we start taking chances putting TAVR in dying patients, they're not, and it goes sour, you know, they come down on us.
Well, I guess the other alternative is, unable to cross and put an Impella to temporize them, so I
An
think
Impella in
ECMO
our
is a
institution
strategy.
of 5.5 Impella is 42,000 Canadian. I don't know what it is in the States. So, there are expensive issues. Obviously, when we operate on people in cardiogenic shock with aortic stenosis, they do better than we expect
For
because
sure.
we relieve the gradient. But I still think there is a role.
Greg, I think you wanted to say something about this. I have to say, we did do bailout TAVIs at the beginning. We've kind of stopped doing them now. Yeah, it's a very expensive solution. Either they will survive, the ventricle has still some reserve, like this case, or they doesn't have any reserve, and you shouldn't be doing anything to the aortic valve.
That's amazing save. The criminal act here was 13 years ago, and I know you weren't the chief. But who allowed her at Leipzig to get a too small, wrong type of valve?
Yeah, that was definitely the wrong decision at that time. We should have done a Ross operation. But at the same time,
Ross
as you know,
or
Fred,
mechanical?
As you know, Fred Moore was not a fan of Ross. Like, we've had to resuscitate that
Yeah,
program
but Fred
now.
liked mechanical valves.
A mechanical valve with a Boston.
Is this a culmination of patient shared decision-making gone awry?
Yeah. So next session starts at 10:30.
Hey, Mike, can I make a quick comment? Just
Yeah.
number one, and I said 29, not everybody gets 29. The goal is the valve opening matches the patient native annulus, right? This small patient, probably his annulus 17, 19 millimeter. That's why 23 works very well. And another question for you, did you leave the ascending alone?
No, replace
You
the
replaced it,
ascending,
okay,
yeah.
good.
Ismail, that bar of calcium going in the muscular septum, is that a problem for you for the Ross?
It could be. It could be. It's something you'll have to assess in the operating room to see whether you can do it or not. I think what I draw from your case, which I think everybody should really be paying attention to, is in 2018 when this patient presented back. You shouldn't just we shouldn't. I know your inclination would have been to intervene, but simply on the number on the echo report, we either have to stress the patient to see what the gradient looks like. We have to look at the actual echo images. When you know that you're starting off with a 19 millimeter valve, it doesn't matter what that number is, if it's 27 or 31. 19 starts you off with such a small opening to start with. Look at the echo images, and if you see that the opening is very slight and there's acceleration of flow, there's really no point in waiting for that on that patient unless the patient's 84 and you're just trying to buy time to avoid surgery altogether. But if you want to see that patient, that 62-year-old, blowing out their 80th birthday candle, you got to intervene now. It's, in my opinion, pointless to try to wait till the number really matches the definition of severe aortic stenosis, because that ventricle is clearly working harder than it should. this patient, it's never going to be a question of if she needs a re-op, it's only when. And the sooner you do it, the more you avoid this burnt-out ventricle. Luckily, she still had contractile reserve, but she's still leaving with a 38% ejection fraction, and she's not on the same survival curve. So anytime we see these patients with small valves, it really is important to look at the images,
To stress
them, and then just find a good reason to do it, as opposed to trying to find reasons not to do it.
Another great point.
Yeah, that
Okay,
was
Mom.
great. I really appreciate the fact that you came up here and gave a case of your own institution, your own center, that maybe in retrospect you would have done differently, but that happens at everyone's institution. That happens to all of us. We get into a very tough root case. We say, oh my God, I just got to get this valve in and get out of here, or I'm not going to get out of here. It's, there but for the grace of God
Thanks,
go I.
Thanks, Mark. So let's take a quick break back at 10:30, right?
bet.
10:30 sharp.
10:30.
Yeah.